All right, so CAD/CAM, inlays. Now let's start with inlays. So what do we know about the difference between an inlay and an onlay? Right, so onlay, you're covering, think about, I guess, on top of the cusp, and then inlay is sort of in between, right? So we'll start with inlay, which if you kind of look at it, it's kind of like just a MOD prep or a class 2 preparation, right? Where you have a large restoration that instead of using composite, you rather use a material that's all kind of polymerized or cured in one whole unit. Because if you look at our direct composite, what do we have to do when we fill an MOD, let's say with composite? You got to layer it, right? And why do we have to do that incrementally? What's the reason behind that? Polymerization shrinkage of the composite. So based on our operative class, what's the recommended increment that we build this up in? About 2 millimeters, right? Max, okay? So we're going to layer or add on 2 millimeter increments of this direct composite. So the advantage of that is you can do it chairside, right? And it costs a little less. And it's simpler, and then if something kind of goes wrong, you can go back and repair it. Okay, what's the disadvantage of it? Well, it's a little bit more technique sensitive, right? You got to jam this little wedge in, you got the little sectional matrix, you got to put the little band on, right? You guys still use the Garrison thing, right? And that Garrison thing just like pops off, and you're like, oh, I got to get it back on. And then you have a big ditch in there because you wedge it in properly, right? So until you get good at it, it can be a nightmare, right? So that's sort of the challenges of that. And then the material doesn't come to as full of polymerization as maybe your other materials, okay? So what if you, instead of kind of incrementally kind of adding to it, you just had, let's say, a whole block of composite that's already polymerized together and it's shaped in the exact kind of cavity or the preparation that you had prepared. So that's what we do with this indirect composite. So really the indirect technique is making an impression of that contour, pouring it up, and then in the lab making this composite block that would fit back into the mouth, okay? So the advantage of that is you can use different type of materials that come to a more kind of full polymerization. It's a little bit stronger, okay? And then you have better control of the contours because you can take your time in the lab to kind of design it exactly as you want, as opposed to your direct where, you know, you got an hour blocked out for them in your office, or in this school you have 3.5 hours, and you're sitting there and trying to kind of contour it exactly how you want it. Okay, so that's the indirect composite. So that composite we would say is stronger than the direct composite. Okay, if we go another step up, well, what if instead of using a resin plus filler combination, which is a composite, we use some sort of glass ceramic? So the glass ceramic has better wear properties, it's stronger, and it has the same advantages. You do it indirectly, so you can do it either in the lab setting on the stone cast, or you would do it CAD/CAM style, okay? We have full control of the contours. But the disadvantage is, one, cost. It costs a little bit more, okay? And it's harder to repair. You can't just add composite to that because it's ceramic, all right? So these are the differing kind of modalities of treatment that we have. And as you go through your clinic experience here, our clinic faculty will help you kind of distinguish and determine which of these methods are probably better for that certain clinical situation, okay? Because you're going to have a variety of situations, and we can't go through every single possibility that's out there. But the idea is, inlays, you don't need to cover the cusp yet, because you have sufficient tooth structure that will prevent that cusp from breaking off, okay? At some point, you're going to get to the point where you say, oh, this is getting real thin. I want to jump to an onlay, and we'll talk about that in a sec. All right, so just some basic inlay prep design features, and a lot of this is kind of a repeat from your gold crown or gold Inlay Onlay class, but just wanted to reiterate. Part of it is you want to have a path of draw, right? So the first thing you got to visualize is where your cavo surface margin is, okay? Where the ceramic is going to meet up against the tooth. Then you look down and you see where all your floors are, okay? And what you want to see is some distance, or another way to put it is you want to see the wall, your axial wall, okay? So if you were to outline it, it would look something like this. So as long as you can see the axial wall in all directions, then you know you have a path of withdrawal. Okay, so that's conceptually what you're trying to visualize as you sight down this occlusal from this occlusal view. Okay, if one of your walls are undercut, guess what? You're not going to see sort of that grayed out region, and you know you have to lean your burr. Okay, so compared to your crown preps, when you guys form these little outlines, I need you guys to exaggerate that draw or that divergence a little bit more than you're accustomed to. Okay, so when it comes to prepping, these inlays are a lot more technically challenging than any crown prep or onlay that you can have, because you have more of these walls to look at. Okay, so look at your boxes. You have boxes on both sides, right? You also have your central groove, your isthmus. Then you have your axial walls, everywhere. So there's just more things to pay attention to, and you just need one little area to that's undercut, and the whole thing will get hung up. Okay. Whereas some of the other preparations are a little bit more forgiving. Okay, so look out for your path of draw. So that concept still holds true. All right. So path of withdrawal concept is critical when visualizing the preparation design for inlays and onlays. Okay. The other thing you want to do too is compared to your gold crown or your gold onlays inlays. Remember, gold you just have to wax up and then cast to. So any little corner, you can get the metal to cast into that sharp area. Okay. When you talk about a CAD/CAM fabricated prosthesis, what's the method in which that's manufactured? Well, here it's with two little burrs that grind it out, and that burr has a diameter of 1 millimeter. So you need to be able to visualize, is that burr going to sneak in to that little junction? Okay. So it's critical to have your preparation designs everywhere to be kind of smooth and flowing and no sharp turns, okay, and definitely no sharp angles. So you want to visualize the burr and make sure it can go, and you can see here, just kind of get into all those little areas. So one more time, okay. So this principle I think we've talked about already in our crown prep design, right, where we had you round out any of the sharp points, okay. So same principle applies, but not only on the occlusal reduction, but looking down this view, you want, to visualize those smooth, flowing, rounded corners, okay? So something important for you guys to start to develop an eye for and know when is it too sharp and where do we have to round out, okay? So same with your boxes. You definitely want those divergent, right? So you got a path to draw. So from this view, I know you can't just extract the teeth and look from there, but that's sort of the image that you want in your head, is my box kind of flared out like that, right? That's going to allow for that prosthesis to just drop in. And then at your box area, so this is just talking about undercuts. So an undercut exists on the walls that are exposed. So this type of area will need to be corrected before the restoration is milled. Otherwise, it will not seat, okay? So the CEREC software will mill restoration. Okay, so the restoration, if you have an undercut at this external surface, it's actually going to mill that to where it should, exactly how you designed it. Okay, meaning that if you have an undercut, you're not going to be able to seat that prosthesis down because the actual inlay is going to be wider than you have space for. It won't drop down. Okay, this is for the external surface of the area. So anywhere that you've drawn your margin, that's going to be kind of covering the outside or come in contact with the outside of your tooth. Okay? This is contrasted by something that is undercut on the internal surface. So if you look at the picture on the right, we actually have sliced through that inlay prep, and we're looking at that isthmus right there. And you can see how the software has virtually blocked out the undercut there, right? So the software is able to recognize an undercut on the internal surface of that prep, and it'll virtually block it out, and then you can seat it all the way down, okay? It doesn't do that for the external surface, because if you blocked it out, what are you going to have? An open margin, right? In this situation, on an internal wall, are you going to have an open margin here? No, because remember, this is a cross-section of that isthmus. So where is your margin in this situation? It's right here, right? As if you're looking straight down. So your margin here is closed. You're just going to have more space for cement there. Okay? Probably lost a few of you guys, but we'll revisit this before your exam. All right, so the last thing I want to talk about is, again, rounded corners. Round these out as much as you can. Okay? So your exit angle, so this is different than your gold preparation in the sense that, remember, we're dealing with ceramic now versus gold. So remember, gold is really strong even at a thin area. Whereas ceramic, you rather have a bulk of ceramic at these exit angles. So I'll show you this little picture. And the purpose to show you this is that you see how this area is beveled, where this has sort of a butt joint. Okay? So we prefer a boxed exit angle versus something that is sharp. Okay? So the idea is that you want something that is more to a butt joint. So when you go prep your inlay onlay, don't be afraid. You almost need to extend these out wider than you think, because you definitely need separation between the teeth here. So you need at least that tip of that explorer to pass through here. Okay? So don't be afraid to widen out these boxes here to get to this boxed exit angle. All right? Any questions about your inlays? So let's quickly talk about onlays, and the idea is that we want to have some sort of cuspal coverage. Okay? So there's many different designs for these things, but let's go over the indications here, right? So what you want to do, or an onlay should be considered, let's do this part. So for the replacement of an MOD amalgam, when sufficient tooth structure remains for retention and resistance form. So this is just saying you still have, so this is from your traditional Inlay Onlay kind of textbook, okay? We're going to sort of cross out this retention resistance form criteria because, well, in the sense that if you can now do something that is all ceramic and bond to the tooth to gain our retention resistance form, okay? So we'll have a few slides on that principle and sort of these non-retentive prep designs. So there's been a shift in sort of the way we think about these onlay preps because of newer technology and newer materials. So obviously if you're using the traditional method in gold, you got to have enough walls for that onlay to stay on. Okay? So we know that because these restorations rely on intracoronal retention, inlays and onlays are contraindicated unless there is sufficient bulk to provide resistance retention form. So again, an old principle. So they talk about MOD inlays may increase the risk of cusp fracture. So when you run into that situation where you run the risk of a cusp fracture, then you want to switch to an onlay to cover it. Okay? So extensive onlays required when caries or existing restoration extend beyond the facial lingual line angles and are contraindicated unless pins are used to supplement retention resistance form. Again, an older kind of thought, right? So we have certain advantages and disadvantages of onlays versus full coverage. I'll let you guys read through those yourselves. Okay? So the question is, well, how do things change when switching from a gold to CAD/CAM ceramic? So this is really the part I want to emphasize, is the idea of you have these non-retentive preparations, right? So when you switch to an all-ceramic system, remember we can adhesively bond or connect the ceramic to the tooth. So it almost acts like super glue, right? So it just glues it on. So the important part here is you got to analyze how much enamel that you have left, okay? So if you look at the preparations at the top, you would realize, well, there's not a lot of walls that prevent this restoration from just rotating off, right? If you were just to conventionally lute this together with a luting agent, well, the thing's just going to roll right off. There's no opposing walls to prevent that movement. But if you look more closely, you can see there's a band of enamel that covers circumferentially around the tooth. And what do we know about enamel bonding versus dentin bonding? It's a lot stronger, okay? So when you look at these non-retentive preps and bonding a all-ceramic material, you want to look at the amount of enamel kind of left over to bond to, because that's going to be the part that's really going to hold your restoration onto the tooth. Okay, you're not looking at the height of the wall, the axial wall, things like that. Okay, you're not relying on that. So here's another picture, and these are better examples of the width of enamel that you ideally have. So if you look at the two premolar preps, what do you notice about the width of enamel there? It's huge, right? So as you slice, so pretend you take some slices, cross sections of these teeth, right? As you move closer to the gingiva, does your enamel band get bigger or smaller? Smaller, okay? So actually, instead of prepping down and getting axial wall height, you're okay having a conservative prep by not reducing as much tooth structure, because the higher up you are, right, the higher up your margin is, the wider that band of enamel is, okay? So it's actually to your advantage to not drop your margin, let's say, to the gingiva, if you can, okay? So if you had the choice here, would you say leave that preparation as is, or do I want to drop and kind of put a margin, right, your like traditional shoulder margin onto that tooth? Well, when you drop and put that shoulder margin and drop it down to the gingiva, sure, you're getting more axial wall height, but you're sacrificing a lot of that enamel to bond to, okay? So that's sort of the shift in dentistry that we're seeing, is that we're transitioning more to this conservative type preparation and leaving more tooth structure intact, because the technology and materials available to us allow for us to still have a prosthesis or restoration that adheres to the tooth, but at the same time we can conserve that tooth structure. And what do we see when we conserve tooth structure? The advantage of that is, one, obviously structural integrity, but two, you do less damage to the pulp, right? The more tooth structure you have remaining, the more of a buffer it is to the pulp, the less trauma you're exerting on it, because you're grinding that tooth less, okay? So anecdotally, I'd say that we're seeing less issues with needing root canals after a lot of these large preparations when we do something a little bit more conservative type preparation. We're not reducing as much tooth structure, right? So that's the principle. Non-retentive preparations, we're seeing a lot more of these nowadays because of the good bond that we have to the enamel, right? So here are some examples. So you can see the top preparation, right? If you were to just use a resin-modified glass ionomer, so look at that top middle picture, right? How the hell is that thing going to stay on there if we did it conventionally? It wouldn't, right? There's almost, just one wall on one side. That thing could easily just roll off towards the lingual. But since we're bonding those into the place, we get success even at, this is a picture at 5 years that they've documented, okay? All right, let's go over this. So inlay design is going to be an MOD, all right? So that's tooth number 14. Tooth number 30, there's no real ideal prep for onlays, because it's really, as the video showed, there's so many different scenarios with which cusp is undermined or which is not. So we just kind of arbitrarily picked sort of one design, and what you're going to start off with is an MOD prep, okay? So traditional MOD, make this pretty wide, so we said at least 3 millimeters deep and 3 millimeters wide, and then you're going to drop your box, and then we're just going to connect your box, okay? So like they were saying in the video, sometimes, this box here is deeper than where your shoulder is here. Well, in that case, instead of kind of taking the shoulder all the way down and making it even, you can just transition it up. As long as it's sort of flowing, you can make it like a roller coaster, okay? So no sharp angles is sort of the idea. But just for the sake of our exercise, we had to give you something to shoot for. So essentially it's an MOD prep, and then you're going to connect the two boxes together just in a straight line. You want to have 1.5 millimeters reduction. So these are the parameters that we've kind of set for you, just to have some goal to shoot for. The big key is any of these angles here, especially as you get to this box, keep this rounded. So just always think, can a burr 1 millimeter wide sneak into these areas? All right. So we need you guys to kind of start thinking through and kind of critically analyzing your preparation, and then ask yourself, is this going to mill? And of course, you have your diverging walls here to allow for a path of draw. Okay. So what we're going to mill out of is this Sirona Block C, and it's actually a feldspathic porcelain. So if we went back to that first slide where we had, the different materials, you can do it out of composite or some sort of ceramic. So this is going to be an indirect ceramic because we're going to do it outside of the mouth. And then you can see it's not as strong as something like Emax. So Emax is up here in terms of flexural strength. That's at 360 megapascals, and Emax is lithium disilicate. Okay, so it's still a porcelain. It's just not as strong as our Emax. But the advantage of this is that you don't have to fire it. Remember, Emax is in the purple state, right? What do you have to do before you can seed it? Well, to change it from purple to tooth colored, you got to crystallize it. With these blocks, it's not as strong, but you don't have to go through that crystallization process. It's already sintered into a block form. Right? So this is what it looks like, and then this is what we're going to use to mill. So we're only going to mill the onlay. So tooth number 14 onlay. Okay? And then we're going to bond it into place with cement. And I'll go over some of the steps for that. Okay? So let's switch over. Let me give you a quick demo, just a refresher of how to navigate through the software, right? So everybody probably get out your manuals because it's not well written out. We have some updating to do with the steps for the manual, and it's real important to know these steps because I don't have a video for you guys, right? So the thing you want to do is image your preparation. Okay, so that's our prep. And the important thing is to be able to see your margins. And then so you want to kind of tilt it to the sides and make sure that everything is captured. You're also going to get your opposing arch, and then you're going to do a bite scan. And then the bite scan, you want to get it on the prep in one of the adjacent teeth. So adjacent teeth, you want a full kind of tooth next to that prep. So this is a critical part, okay? And make sure when you have the type it on's articulated, you're going to do it by hand, but you want to make sure that's stable, okay? And then when you orient the camera, you got to think about how the patient's cheeks are in the way. So don't go from like the back of the head and scan that way. You got to come from the front as if their mouth is open. So you want to orient it that way. And all you need is one good picture for the bite scan, all right? You don't want to do multiple ones here. So be sure to write all this down because we don't have a video for this. So one bite scan, and then you're going to move on to the next step. So we're going to click the arrows. And then from here, this is the important part. It doesn't automatically do this. So you go step 2, make sure I hit trim area. So you should probably write that down. So this is what trim area does. And look real closely. What you want to do is tell the computer where your interproximal separation is. So you have this line, you're going to double click here to start it, and then you're going to navigate this line so it splits through the margin and the adjacent tooth. So it's important when you image that you don't have the neighboring tooth overlapping where that margin is. Okay? So you see how it cuts away that side? It's going to be important to do this because we're going to need to visualize where our margin is, and to get the teeth out of the way, it's going to be easier to marginate when the teeth are out of the way. So again, I'm going to go to this side and double click, and I'm going to try to split and not get the margin. Okay? So if this happens where it cuts out the wrong side of the tooth, you just hit invert selected. And what you want to be left with is this tooth by itself, almost like you're trimming your die. Okay? So trim area, and then of course you want to draw margin. So this just makes it easier for you to draw your margin because now you can see that all the teeth are out of the way. All right? So you want to start with your margin, and then it has that defaults with the auto margin finder. Okay? So I want you guys to do this as independently as you guys can. All right? Because we got to kind of move you guys up and start to do things a little bit more independently and put on your big boy pants, because you guys are getting close to where you'll be seeing patients. All right? So make sure you know what you're doing here. All right? So you're going to go through, kind of check your margins. So this is where a clearly sharp, defined margin is going to be easy for you to delineate and kind of see exactly where you need to draw your line. If you find that you have any kind of blips or anything like that, you probably want to go back and then refine that margin and then re-image to get a better mill. All right? So like your KVO surface, you obviously, a nice, crisp, clean margin. All right? So the next part is define insertion axis. So you see that how tapered my preparation is? You almost see no yellow on there. If you have a large undercut, you may see some yellow. When you image, when you go and take your first picture, it should include the preparation, and then you want to angle it so that you can see your path, or you can see all the actual wells, because this is going to be your path of insertion. All right? So if you see a lot of yellow at this step, you may need to go back and then over and taper the areas that you have your undercut. All right? And then we go to design. So it'll run through a design proposal. And then you guys have played around with the software a little bit, but this is another chance to get better at it. So the idea is we want you, obviously you're not going to remember every single step, but the idea is that we want you to be comfortable, one, just like moving the mouse and stuff. That's one. And then two is figuring out what all these kind of tools do. Okay? So if you wanted to look in approximately, the nice thing after you've trimmed the model is you can hit this trim model button, and then it'll hide all the neighboring teeth so that you can get to this interproximal region. Okay? So here you want to kind of smooth out or adjust the contact so that your contact is in the ideal interproximal position. So obviously our contact shouldn't span the whole occlusal cervical dimension, right? You want to have a little bit of an embrasure space where there's a little space there. You want to concentrate that contact right there. Okay? So you can spin it around and then do the same thing here so that you have your ideal contact area. And then you can check your occlusion and make sure you're not in hyperocclusion. So you can turn on your contacts. So there's all these differing buttons that you just kind of need to play around with to figure out where you're at. So if you wanted to, let's turn on our tools again. If you want to increase the contact, you can take your shape tool, and there's anatomical and circular. But basically you can grab a whole section and then just kind of increase certain cusp areas. So this is our functional cusp. So if you wanted that in a little bit heavier occlusion, you can raise that up. Okay? So when you're done designing, then you go to the mill phase. So what I'm trying to look for is good interproximal contacts in the ideal locations, and then some occlusal contacts on your functional cusp. Right? So those are the two parameters I'll be looking for. Once you think you got that all good, then you go to your mill step. And this isn't connected to the mill right now, so we have an error. But basically, it'll ask you to insert the block, which will give you, and write this down. It's a CEREC. When you go select the block, CEREC block 14 is what we're going to be handing out to you. Okay, so make sure that is connected. And you'll insert that and screw that into the milling unit just like you did with your Emacs. And then these take about 15, maybe less than 15 minutes for it to mill.